Welcome and good morning, Dr. Anabel Gonzalez, and thank you very much for for the opportunity to interview you on your book. And I have it with me. It's EMDR and Emotional Processing, working with severely dysregulated patients. So welcome. Thank you for doing this.
Thank you for the invitation.
Thank you. Thank you. So wonderful. I suggest we just dive into it. As I discussed in a previous video where I discussed the outline of your book, it contains really like a huge amount of both theoretical and practical information on how to work with special types of clients that have difficulties regulating emotions. So I think discussing the whole book would far exceed the scope of this interview.
Yeah, probably.
So perhaps we could like zoom in and make it like as practical as possible and valuable as possible for Belgian EMDR therapists.
Mm-hmm.
So let's focus perhaps on a specific case I got straight out of your book that will resonate, I think, without any doubt, to a lot of colleagues, including myself, at the case of Nelson. You remember the case of Nelson?
Yeah, yeah.
So it's if I get it correct, a 25-year-old man that suffers from anxiety, sleeping problems, tiredness, headaches, a clear block in his studies and his life. So it's clear that he really suffers. It's somebody that really is suffering, and he also wants to improve and get better. So that is interesting. However, and that is why I bring this up, is that when exploring the history as good EMDR therapists as we are, there are no clear events in the timeline. It doesn't have a dissociative disorder either. So that is really important to mention. No dissociation present. When go over the history, everything is normal. I don't have any problems. Nothing is going on except my issues now, the block, the sleeping issues. Nelson also had like a previous therapist with whom he worked 4 years. Yes. So, and they tried to work on some.
I don't remember the years now, but yeah.
Yeah. Okay. Yeah. So he already did some therapeutical work with another therapist. Also with EMDR, try to like figure out on which kind of memories to work on with standard processing, but nothing seemed to work. And this, it really resonates with a lot of clients.
Yeah, I think it's interesting because when we think on emotion dysregulation in our mind, the patient that comes is someone very anxious and showing emotions in an open way. But those are the patients like Nelson who are more challenging for us as therapists, working on very emotional, on trauma issues, because they cannot connect with their real emotions. Nelson is a case of dismissive attachment. And I think is the more difficult issue for us, because they don't know their history, their real history. Yes. They don't know how they feel. And it's not really a question of how to process memories with them. We need to do a previous work for them to understand what happened with them, for them be able to talk about relational issues, emotional issues, because they have no access to that. They even don't like it. Yeah, don't talk to me about the past and these things. Yeah, I don't like it, or I don't want to talk about emotions. So what do you do in a psychotherapy? Yeah, and they can work in other kind of therapeutic approaches, more based on doing things, on behavior, because they can understand that. But here it's like learning a language. Our therapeutic process is more like learning a completely foreign language, the language of emotions and relationships. They don't live in them.
Yes, yeah, it's very challenging indeed, because as an EMDR therapist, you try to help, you try to explore history, you try to try to find when did it begin, when did it worsen. You try to actively engage to help the client, and then you have somebody that's, no, there's nothing there, I don't feel anything, it's normal, I don't have problems, my parents were normal. And that is quite striking. And then what you also wrote in the book, and I recognize a lot, is that we make the conclusion EMDR doesn't work for this type of client, and we actually worsen sometimes the symptoms, because people feel like incompetent, they don't feel they can heal. It's really striking to recognize what you wrote in the book. Are there, how would you already explained a bit, like we first need some other steps before EMDR? Does it mean we can never use EMDR with this kind of patient? Or
I think sometimes we have a kind of two mistakes, I think. One is consider that EMDR is just trauma processing. The phase 1 and 2 are something very complex. I know some colleagues say they are not necessary, but for this kind of patients, it's very necessary. And the question is not, okay, tell me your history and I will write the relevant memories. With this kind of patients, discovering the history, it's a therapy in itself. And we call it phase 1.
Yes.
But we need to develop more what to do in phase 1 and 2 and how to prepare the patients, because we have a very clear structure of how to process a memory when the patient can access it and process it adequately. But when they can't, we don't have any schema of how to prepare the patients. From the emotional regulation point of view, those patients tend more to suppression or sometimes to control emotions.
Okay.
And I differentiate between the two of them in many articles or books. They are considered synonymous, but I think they have a different element. In suppression, the patient is more alexithymic. They don't notice the emotion, and when they notice, it's something very subtle and they can push it down very easily. The control patient notice the emotion, but they don't like it. And they decide not to feel, or I don't like this emotion, and that's all. Yeah? And they are trying to contain and control the emotions. This second one is more conscious about emotion, and they need to learn another type of control, because we cannot say a person who tends to control emotions, okay, let them flow, because it's impossible for them to assimilate. We need to use metaphors to explain them how's the process, and they need to feel a lot of control all along the process. And at the end, in the horizon, we are drawing an image of a better type of control. I have a better type of control to offer to you, that is security. And it's something different, and it functions that way, and they need a lot of information. The suppression people, it's different, because they don't know that they don't feel, or they don't know how things affect them. And here, the work is very much from the therapeutic relationship with a therapist that is understanding what is happening. And we need to be there, to be there, to be there. And at the beginning, not with some distance, because they cannot tolerate a very intense or very close relationship. Yes. They are avoiding attachment. They are trying not to be in the middle of something that can activate their attachment system. Yes. So we need to do a progressive way of working with them, and at the beginning from a very rational point of view. They need to have the concepts about what emotions are, how emotions are felt, and they need to do a process of first understanding and then start to notice something, but a very little. Something we tend to do as therapists is using this kind of reflection. If the patient is not connected with emotions, we need to do connection with interventions or techniques that helps them to connect to the body. And I think this is not true.
Okay.
Yeah? They need, before to do that, this is important, but before to do that, they need to understand what connection is, what emotions are, and they need, when they have the structure, they can start to connect a little bit, and these small connections needs to be put in a global understanding. Yeah? So if I'm correct,
actually, yeah, we need also to be very kind with ourselves as therapists, because we need a lot of patience, and EMDR, as in the standard way of thinking it, as in processing memories, will not work because people don't have the language. They're afraid of emotions. They underregulate or overregulate, and of course, if you want to do EMDR, you need all those kinds of elements.
Yes.
To process something. Yeah.
Yeah. If the person cannot connect, they cannot access the memories. Without accessing, there is no processing.
Yes.
But this is not a closed situation. It's something that a language can be learned. But we need to change our metaphors also, because EMDR is sometimes very powerful, very spectacular, and all we have in our mind, those kind of fantastic patients, we have some sessions and everything changed.
Yes.
Those patients are not that way. And if we have this model in our mind, we will become frustrated, desperate, and this won't be helpful. They need a different rhythm. So for me, the metaphor is more like teaching a language. They need to learn a new language. And probably before learning the language, they need to understand why it's important for them to learn that language. I think it's something we need to think about from EMDR, because sometimes we have a good definition of what to do with traumatic memory, but we don't have a good definition about many other aspects. We said how to do the phase one, how to prepare the patient, and these kind of issues. Yeah, how to understand this idea of the difficulties of some patients with their memories, internal processes, and so on. So the idea of the book is to find many of those aspects, not from this psychodynamic point of view of the fences, but from the recent research on emotional processing, emotional regulation, and what we know at this moment about all these topics. This book came from a PhD project from a colleague.
Okay.
And we were 2 years reading about this. And during these 2 years, we didn't write anything or we didn't elaborate this. We were just reading and exploring. Yeah. And I think many issues that we are calling defenses are better defined as emotional regulation, dysfunctional strategies, or things like that.
Yes. Okay. Yeah. It's indeed it's a very, very interesting book, and I would like really to suggest people, EMDR therapists or other therapists, even without knowing really the EMDR model, to read it, because there's a lot of information also on a theoretical level about the emotional processing and how it plays a role in therapy. If I could permit, like, if we go to the specific case of Nelson, for instance. So imagine I, as a therapist, I get this patient. He already did therapies, a lot of therapies. He's like perhaps a bit frustrated about the lack of progress. How could I, and of course it's a big question, so I don't expect a comprehensive answer, but what could we do? How can we start with
you said something very important, that is the more relevant resource for a therapist working with this kind of patients is patience. We need to be very, very, very patient because they need time. And if we try to see the changes that we see in other type of patients, we can push the patient to a rhythm that is not theirs. We can become frustrated or desperate. We can feel that thing is not doing well, and this is not good for the patient. And sometimes if a good thing is to do a first evaluation of how the patient is, and from each 6 months, we can review it and see how the patient is and how the patient feels. But because it's very frequent, these kind of cases are very frequent in supervision. And when you ask the therapist, okay, but how the patient was at the beginning of the therapy and how the patient is now and how the patient feels, and they say, no, the patient is happy with the outcome of the, and say, oh, okay, so maybe the problem is the desperation of the therapist for seeing, and those patients move us to search for the key. We want one technique, something very, I didn't do course enough. I need another one, another technique, another approach, apart from EMDR, to help those patients. And sometimes with, I have a patient inactive now, because this case is an old case, but I have a patient inactive now, in active therapy, I mean, of this type, and we were working for years, not every week, but we were working for years, and she's improving. She's completely fine. No, she has some periods of, during the pandemic, she was a little bit with low mood, but she was never in a severe depression like previously. So I think she's better. She feels better and she's happy with the therapy. It's a therapy with a kind of confrontation, as you said, but she was with another therapist and she said me, okay, I need to come with you because you say me things like they are. Because they need this change in their thinking that is very rigid, and they need to modify it. And the last session, I was very happy. And sometimes some time ago, she cried for the first time, and I was very happy. And she said, "You are a bad person." I said, "Okay, I am." But you know why I say that? Because she was starting to feel weak and don't escape from that. And the last time she was talking about many things, and in some moments she started to feel sick from the stomach, and a very typical somatic symptom in her. And she said, okay, my stomach is saying that I need to talk about a different thing. Okay, and this is not a dissociative part. Yes. It was a normal language, but she is doing a lot of changes, but in a very slow pace. That's the issue. And we need to know that things are that way. They are not spectacular changes in those kind of patients, and it's okay. They probably could not tolerate a very rapid change.
What was like very interesting to read is we're learning in basic training that there are several things that can happen during processing, for example, and there's like a focus, a bit of a focus. It's not on purpose, of course, it's to learn the EMDR, but there's a focus on what can we do if patients are really getting high levels of emotion, and then we try to get them in this window of tolerance. And what I read in your book, it's not only about this limited view about the window of tolerance, but it's emotion regulation is about very different things. It's about how people cope while ruminating, while avoiding, idealization, all these kinds of things people can do. And I think that's very interesting to realize with the work as an EMDR therapist, not only to think in terms of the window of tolerance, but also like reading your book and realizing there are a lot of things that can happen.
Yeah, I don't like this metaphor of the window of tolerance, because I think it's very simplistic. And we think we are understanding, but it really is not understanding. Yeah, if we think about it, it's just a question of too much, too low. But what this means, nothing. For example, a patient with a tendency to high rumination, that is a severe problem of emotional regulation, tend to increase emotion sometimes during the processing, because the bilateral stimulation is functioning, but they are increasing the emotion through rumination. So if we don't identify that and work specifically with rumination, what solution can we have from the tolerance window metaphor? Nothing.
Yes. I think also in general, what is confusing now also, we have in the EMDR world, and I think I can easily talk about it, we have different opinions on how to work with memories, with difficult stuff. We can say, like, if somebody is avoiding, you can add exposure elements, threat cues and stuff like that, like the colleagues from the Netherlands are doing. It could work, I guess, in certain situations. Do you think it will work in every situation?
If it's really avoidance, there is no technique that works in all the situations. Start from that. But if it's really avoidant, it can work. In fact, there is research from the Netherlands combining exposure and EMDR in both directions. First exposure, then EMDR, and the opposite. And it works better doing exposure first and EMDR in the second place. And it makes sense, because if the patient is facing the memory and being in connection with the emotions, it's easier. If they tend to avoid them all the time, sometimes they don't even want to do EMDR. And if they do, they don't do it really because they are like, yes, but not. Yeah.
Yes.
So there are some different techniques we can use. Yeah. For example, these flash techniques that many people are talking about is something that makes sense with avoidant patients, because you are not focusing on the memory, you are just connecting a bit and going to other places. But at the same time, you are doing bilateral stimulation. So in a way, you are processing disturbance with them, but they are not needing to go to the memory and go to the emotions and try to maintain in contact with them. So we need to think on this kind of interventions. But I also have seen a tendency to call avoidance to every person who don't want to be in contact with an emotion. And for me, avoidance is, I tend to use terms in a more restrictive way, because if we call the same to many different situations, we don't know really what to do with them. Yeah. So for me, avoidance is more like a phobia to the emotion. Yeah? Phobia of emotions or fear of feeling.
Yeah.
And this is different from control. Of course, the control person, underlying, they have fear, but it's a more rigid pattern. They are trying to contain or control, and they say themselves what they have to feel, what they don't have to feel. It's a different patient, a patient that is afraid of feeling and a patient that is rigid and try to control them. We need to do different things to prepare them to access and processing the memories.
So perhaps we can also say there are people that have witnessed very difficult situations, like typical big T trauma events, and that are avoidant mainly of those events and confronting them. So that could work well, but there are also people like Nelson that don't have clear big T events, and the emotion regulation in itself is the problem. So it's difficult to work with the memory because there's no memory. So we first need to like give patients a language, help them understand feelings better, and then we can work with them. So is that how I could see it?
Yeah. I think if we have a more detailed and differential understanding of what emotional regulation is, we can think and reflect on how to work with this patient and how to work with this other one. And yeah, if we just think emotion dysregulation, we just need to do mindfulness. Yeah.
Yes.
It's helpful for some people, but it's not helpful for everybody because they are not in the same point. Yes. They don't have the same problems. They don't have the same strategies. So the book is based in a more personal understanding of the cases. Some concepts may help us, but we need to go to the case. And for going to the case and the specific situation of that person, we need to have some elements in our reflective thinking. We need like an equation. Yeah. And if some concepts like the window of tolerance is not very useful because it's very unspecific, we don't use it. We go more to other type of elements to introduce in this equation. And then we can think of how to work with that specific person. And another issue that I think it's interesting, I think we do that, but we don't talk about that, is the analysis of process. How the patient is processing, how the processing is functioning in the session, how they do. And the analysis of what is happening in the session may help us EMDR therapists to develop more our interventions. But sometimes we take techniques or interventions from other psychotherapies. And it's okay, we can do that if they are useful, we can combine that. But I think we need to think from the EMDR perspective. We need to see how EMDR works during our sessions, because, for example, in talking about the window of tolerance, this is one reflection, because we don't have so much problem with people that is over-aroused.
No.
Because bilateral stimulation do exactly that. Yeah, so sympathetic activation, okay, parasympathetic activation, no problem. For other therapies, it can be a problem. But we work differently. But this bilateral stimulation, this parasympathetic activation, doesn't work when the patient is this.
Yes.
So we need more reflection from that point of view. Yeah, and the book is an attempt of opening this idea of the analysis of how the patient process. And during EMDR, not in other psychotherapies, in EMDR therapy.
Yeah, that's also what I found very interesting very valuable in the book, that it's not only about trying to process memories. We also have to look at what is going on into therapy. Why aren't they connected to emotions? Do they even have a language of emotions? And all this plays a role in why it doesn't seem to work yet. Because my opinion is a bit, if you have a brain, EMDR should work,
Yes.
So there's no point in believing that it wouldn't work. Of course, if your leg is broken, EMDR won't work. So there are limits. There are limits to the model, but that is really nice to read in the book. That just not thinking EMDR in the classical sense of just trying to find the memories, trying to solve them, and trying to put very anxious clients back into the window of tolerance, but really like exploring how do people relate to their emotions? What are the origins of these kinds of emotion regulation? What is the attachment style of the client? And then begin to work from this. But for me personally, I was reading this book. I was already doing some stuff without consciously knowing I was doing this.
Yeah.
And that is really fascinating because with these kinds of clients, what I tend to do often is to work with nonviolent communication, how to express in a communicate, like what do you observe, what emotion do you have, what need is behind, and repeating it, or working with emotion phobias, and then hopefully getting somewhere, of course. But it's valuable to read that you really open up the field of EMDR therapy with this model.
And I think many therapists are doing things like that. Yeah, because we deal with our patients, we have a knowledge of how relationship works and many issues, but it's important to understand what are we doing and
Yes.
why this can function, because we solve many situations without reflecting about it. Yeah. And those are some ideas. I don't have the final answer to everything. Yeah. But when I think we can start to reflect on our sessions, our patients, and what we do, because sometimes even in the courses, those of us who teach other people tend to be tricky. Yeah. And we tend to show that spectacular session showing that effect, and the people who are listening think that we have this kind of sessions with every patient all days. And this is not the case. The majority of the sessions are even boring, sometimes we don't know how to do. We need to think and rethink the case many times. And some patients become blocked and they cannot improve, and we don't know why. So that's the real therapy for everybody.
And it's nice to read, actually. Especially I don't know if I'm a beginner but an advanced EMDR therapist already, but we always learn each day. And the case studies for the people that are listening to the interview, if you want to begin with the book, for example, and you want to really dive in, just look at the case studies, for example, from Nelson, where it is clearly explained that it is very difficult. We can feel lost, we can feel incompetent, we don't know what to do, nothing seems to work. Perhaps your own rescue pattern comes very active with these kinds of patients. But if you read this book, or like chapters of the book, and try to combine some elements of it, it can really enrich your clinical practice with patients that are clearly suffering, but do not have these clear events in the timeline. And that was an eye-opener in your book, really an eye-opener. So very well. Do you still have some advice for like beginning EMDR therapists? So when confronted with these situations, once again a big question, but
I don't know. I think depending on how we are, I used to say in my courses to people that there are two types of EMDR therapies, or therapists in general, trauma therapists. That is the phobic one and the psychopath one. Yeah,
the psychopath one.
The psychopath one. Yeah, I'm a psychopath. That is my first patient was a DID patient, and the session was and I didn't become afraid, I became interested. This is the psychopath, and the psychopath finished level 1 and start to work with the worst cases. Yeah.
Oh yeah.
And when there are difficulties, they are even more interested. The phobic ones never know enough to start. Yeah. And we need both things. We need to be a little bit phobic, that is careful, and a little bit psychopath. Try and explore. Therapy, we have guidelines, we have the protocols, we have an instructor, and this is good. I think it's a good thing of EMDR therapy because we know how things are and how the processing of a memory works when it works. But in many cases, it doesn't work so easily. So we need to explore. And to explore, we need to do it with some knowledge in our mind. It's not just doing whatever we think. We can explore in that way. Well, we need to reflect on if this worked, why? And if it doesn't work, what's happening here? Yeah? So we need to trust on ourselves, to do a lot of supervision. I think supervision is very, very important. I don't know how it's in your country, but in Spain, people don't supervise very much, and it's a problem. I think we need a culture of regular supervision to really go deep into the cases and to understand from people who are working with that for a long time. But I think we need to have this flexibility, but this well-founded knowledge to guide our exploration, our trials, and our
Okay, so what I remember is like exploration is really, like being curious is very important, but not too curious, of course, but trying to understand who is the person that is in front of me, why doesn't it work, why does it work, try to explore with the patient how it all puts together. I think also supervision, really try to discuss cases is very important. And actually in my country, I don't know if people don't take a lot of supervision. I personally take a hell of a lot of supervision because I like it. I really like to learn. So it depends on the person, I guess. I don't know.
Yes, of course. But I encourage new people to do it a lot, because I think it's a course can help you in a way, but it doesn't help you to go to your cases, to your difficulties that are quite the same for all of us.
Yes.
Yeah? And solve this specific situation. This is a thing that needs from supervision, from peer groups and things like that.
Okay, thank you. Thank you very much for doing this interview. I don't know if you have anything other you would like to add. We discussed a lot of things. We not very like specific things, but general things. Just to conclude, I really like the book. It's really interesting. It's about emotion regulation and about the process that can occur during EMDR therapy. And it has a lot of not only theoretical information in it, but also a lot of practical examples. And that is, I also noticed that a lot of colleagues and myself, we need some examples also. There are case studies, and it really resonates. And that is most important for me with a book is, does it resonate, and can I do something with it? And it also contains a structured interview which you can use if possible, if the client is ready to explore the origins of possible problems with emotion regulation. That can actually lead to a target plan later on. So very nice work. A lot of work went into it. So thank you so much for doing this interview. And let's see if we can do some supervision in the future.
Thank you for your interest.